Hi, it's Andy and Alan again, talking about a return to healing on Sunday morning, and we're going to continue our discussion about primary care. We're both very devoted, passionate primary care physicians who wouldn't change it if we had to do it over again, despite all the problems with the field. So we want to talk about why. What's great about primary care? Well, not only for us, obviously, because we love our relationships with our patients and being there to see the whole patient and being able to actually put everything together that they're fearful of and they see and they feel. That's the greatest feeling when I come home every day. And honestly, my patients who I've seen for a long time truly appreciate it, even if they were brought up in a very specialist oriented world. But it's good for them and it's good for the system. It is what is the saving grace of the system, as we talk about in the book. So, Alan, I mean, you've been doing this a longer time than me, even. So, what do you think?
So Andy, I've been doing this for 38 years. I agree with you 100%. I hear all the time about my colleagues and their patients who love their doctor. I hear it from pediatricians as well and, some OBGYNs, but, you never hear it about the cardiologist or the gastroenterologist or any of these things. Oh, it's been my doctor for 30 years. Like they would come to my house, they answer my calls in the middle, and I just love these people. It's just not the way it is. And that what makes, in my opinion, primary care so special. It's about the whole person, patient-centered care that to me is based on three words. Okay. It's relationships, trust, and communication. You need a relationship. I tell my patients all the time, I could be a great human being. You could be a great human being, but together we're like a bad marriage. And it just, we don't communicate well. You need to be able to communicate well. You need to have total trust, in what you're doing. Um, and I've always said, when I do my teaching, I gave a talk on opioids and I said, I trust my patients all the time until they screw me. And the residents were looking at me like, you trust a patient with opioids? And I'm like, yeah, I mean, you have to trust your patient. So it's about relationships, trust, and communication going both ways. And that to me is what makes a good doctor-patient relationship. And it is that relationship to me that improves patient care.
And it's really, and you're right. I mean, the two-way, it's a two-way trust and two-way communication. So when I don't dictate to my patients, we promise not to bash specialists in this particular podcast, but like when a cardiologist tells my patient, look, if you don't go on a blood thinner, you're going to get a stroke, in a very dogmatic way. I come and give data to my patient, and I say, listen, and sometimes the patients say it's really hard getting different information from two different doctors. So I say, here's the data. You could ask them for data too. I said, but here's the thing. We have to make a decision that is not fixed in stone. You could change your mind down the road, but here are the facts. I've been doing this a long time. This is what I see. I say they are very myopic in the sense that they only see one thing. I say, but I see sometimes what happens bad from all these interventions that they don't see because people leave them when bad things happen, they come back to us. So the idea that I could, and if the patient says no, I just don't want to do that, the patient is always right, and I feel like not the patient is not going to do everything I want, nor do I have a prescription that's just right for this particular patient. So this give and take, this thing that we know and trust each other, and that we give each other a lot of leeway in terms of making decisions, and all those decisions are flexible. That type of common sense humanistic medicine is really what drives me every day and what keeps my patients really attached to me as a doctor. And that feels good, to be able to do that
No,
every day and explain things.
you know, it feels great. To me, it feels more of than good. We talked about it last week. People used to look at medicine as a calling. I think primary care, internal medicine, family medicine is still a calling where, most of the other medical subspecialties and levels of care is, more of a job and more of a way to make a good living. And yeah, the satisfaction out of, the cardiologist, we always go back to them, sorry, the patient coming into the cath lab and them saving their life, who's truly having an ST elevation MI. They're truly having an acute MI. Evidence there that interventional cardiology will help prevent some of the damage. So we see that it's good. But it brings it back again to that communication thing, and what Andy was describing, the big word buzzword in medicine, I jotted it down when he was speaking, is patient-centered shared decision making. Like that's the buzzword. It's about the patient in the middle. We work with the patient and we help them make decisions that are best for them. And in my teaching, and I do a lot of teaching of residents and students, I tell every day, I say this to a student. Someone says, what makes a great family doctor? What makes a great primary care internist? And I tell them every single day, if you treat everyone like you would treat your family or you would want your family treated, you're going to do a great job. Because the evidence it's on our phones right now. We have things like open AI evidence. I could ask open AI any question now, and it would give me the latest evidence up until a week ago. So I don't have to sit there studying those multiple choice questions to get into medical school that we talk about. We should probably do a podcast on that too, Andy, on,
Yes.
on the whole medical school
Oh
entrance
my God,
process.
yes.
We haven't talked about that. But everything now, the data is at your fingertips. It's about
And,
the art of medicine. And
and the other thing is
people,
this, I mean, this data that you're talking about, this AI, is 90% garbage, if you ask me. And I pulled up things on the AI. That's what the specialists use all the time. They use these little calculators and everything else. They're all programmed with drug company studies. I mean, everything in AI is drug company studies. So one also thing that distinguishes me from the other people is I read the study. I will never ever pull up an AI anything unless I've looked at the study and I don't look at the introduction and conclusion. I look at the tables. I want to see the real numbers. I want to see who are the patients are in the study who was excluded, and mostly right at the bottom, this was partially sponsored by Eli Lilly. I want to see that, and that's something that also distinguishes us. We will dig deeper than just what you will find on Google. A lot of patients come to me with Google stuff. Um, and I have to be the one to decipher it. And I always say, we live in a country, one of two countries in the world that allows drug advertising, and anyone who watches TV knows it's prolific. It's not, it's probably more than cars now, but the AMA has said we need to stop this. I agree. But their reasoning was different. They said because doctors can't be expected to be hit by all this stuff. And I say, bring it on, man. I said, bring on these drug ads because every drug ad I see, honestly, it's like an obsession of mine. I go and I look up stuff. So I'm ready to debunk or support the drug ad that comes on. So I feel like it's a great opportunity when they come in with these drug ads to talk to people instead of being annoyed by it. And I'm not annoyed by the AI and I'm not annoyed by the Googling because I've done enough research and I continue to do research. And that's the whole thing. Osler said, and I have it in my newsletter, this one, that what differentiates the doctor from every other the other profession is the constant, incessant learning that we have to do. We cannot stop in what we know and be done with it. We have to keep learning, and keep being incredibly critical of everything that comes out, knowing that we're living in a drug company world, that AI is now owned by drug companies too, because they basically have bots that hit the studies that they want to be on the top of the AI. So they have millions of hits. We need that for our
yeah,
book, Alan. We need a bot
yeah.
to hit
So,
all our things.
so
But
the,
that's also fun, to do that. I actually enjoy it. It's a hobby of mine. So it's nice to be able to be the guy who knows actually what's going on in the scientific world because medical science is designed by drug companies. When they say science, just take a step back. It's not science. It's manipulated information. So I
right.
never use the word science because as Alan always says, it's an art. And it's, as Osler said, it's an art in which you as the doctor have to be the master of the science. You cannot allow someone else to tell you what the science is, which is often what happens in our world with clinical practice guidelines and other things and experts who come on TV and tell us these things. So, yeah, this is the other part of what we do. We put it all together for you. It's nice.
So unfortunately, I think me and Andy, and I have to say more Andy because he's got goes a little deeper than I do sometimes. Um, Most folks are not, medical learners are not taught like critical appraisal of medical literature. They're not taught how to dissect an article, and I do it all the time when somebody brings up a study and I say, well, who was the study funded by? Like you got to start with that. Like who was it funded by, and has it been replicated? Because one study is one study that we know that, 90% of the time will be reversed within a period of time. And Andy's right about, the open evidence. When you open something like Open Evidence AI, the first thing that comes up is an ad. Um, Personally, I think the TV ads are horrible. Maybe we could have a debate on that one that,
Oh, I hate them
you
too. Don't
know,
get me
not
wrong.
nothing annoys me more when someone comes in, singing the Jardians jingle, and I really want that drug because I'll never go on dialysis and I'll never have a heart attack. So I kind of love that. So it kind of pushes me,
Yeah, it pushes all
away
the
a little
buttons.
bit with that. But you get it every day. You get it every single day with a patient. It is prolific. It's again that medical industrial complex with pharma and device makers. You can see it. I saw one in late night TV a couple of weeks ago. There's something called a Watchman. If people haven't
Oh
heard of a
my God,
Watchman,
help us. God help us.
it's the Watchman is an atrial appendiceal device that they put inside your heart. So we all know about atrial fibrillation. You hear it every day with the ads for anticoagulants and how they're going to make you live longer and better. And again, you have to listen to the side effects of you're going to drop dead from a stroke or you may this or that. But, for people who quote can't be coagulated, there's the Watchman. And it's literally a device that they put in your heart so you don't have this. And they're literally advertising. Like, can you imagine someone coming to the doctor and saying, do you think I'm a candidate for the Watchman? I've
And they
gotten
and they
those
do, and
questions.
they do, and again, The Watchman is if anyone wants a great book on other than our book on medical devices, there's a book called The Danger Within Us, and it talks about how the FDA has basically no criteria for approving medical devices other than maybe a 3 month study. That's all you really need. And the 3 month study doesn't have to show much. It just has to show you don't die in 3 months. The Watchman's one of those really scary procedures that goes in your heart, and so already I'm scared because it's in your heart, it's sitting on your heart muscles, and there are no long-term studies. So that's the kind of stuff we have to look at. And I tell my patients, there's no long-term studies, meaning 3 months. We don't know what it's going to do, but I could tell you your atrial fibrillation itself is not as dangerous as everyone's telling you it is. It's not as horrific. The odds of you getting a stroke are only a tiny bit higher than if you did not have atrial fibrillation. So you could weigh that against this complete unknown device that's about to be attached to the inside of your heart. And again, the people who put in the Watchman, who are telling people to do it, are the ones paid to do it. Alan and I are not paid to do anything. So in that sense too, we are extremely reliable sources because we don't care if you get it or don't get it. It doesn't affect us one way or the other financially. So we're going to tell you what we think's best for you. And that's why I look, Alan, I hate the ads. And when my kids sing the ads, it's really, really disturbing. They used to sing Viagra ads all the time, which was really upsetting. But I get it. I wish they'd go away. I wish the pharmaceuticals would be out of everything. But I want to be prepared when they come to me with these ads, and at least it gives me. I have never put a patient on Jardiance. I've taken tons of patients off it once I discuss it with them. Nor has any of my patients gone for a Watchman. Even though they've been suggested by a lot of cardiologists who put them in. So again, the financial difficulty of having a doctor recommend something where they make thousands of dollars if you do it is very different than what we do in primary care. Again, one of the reasons primary care is so effective not only to the patient, but we haven't even talked about how effective it is to the system in general.
Yeah, look, Andy, our healthcare system is crashing and burning. The new cuts in Washington will make it crash and burn maybe a little quicker. And, maybe that will be a good thing. Maybe people will then realize that, we're spending trillions more than every leading nation. We spend twice as much as the next leading nation. And that would be great if we had better outcomes. But we have worse outcomes on longevity, infant mortality, maternal mortality, pretty much every statistic of equity, efficiency, cost, access to the system, we stink in.
Chronic
And
disease,
really,
yeah, all
really,
this.
really, the only medical intervention in all time that has been shown to improve outcomes and meet the quintuple aim of increased quality and lower cost and value is primary care. It's been the only public health intervention, prevention, primary care that has been shown to increase health. And if our nation doesn't wake up and say every American needs a primary care physician, it's going to lower the costs, it's going to improve the outcomes, and we're all going to live longer and better. It's a simple answer, and you're going to have a doctor that you have a relationship with, that will communicate with you, that you trust, that will treat you like your family. And we've struggled to get that word out, and we're battling everybody else because people don't want to get the word out because it's cheap. Like Andy
It's
said, we
cheap.
don't get a
Yeah.
dime from doing these procedures. It's cheap. We don't get paid more by keeping people healthy. It's crashing, it's burning. The answer is really simple that every American needs a primary care doc. And it makes so much sense to any human being that you take out of is making billions of dollars on healthcare, you know. And the lobby groups in Washington don't want to go along with it. The politicals don't want to go along with it. And the doctors that are making millions don't want to go along with it.
No, that we would stop all that. Not even by trying too hard, just by existing and by having conversations with people, that alone would cut the profits of the pharmaceutical company, the device company, the specialist doctors who rely on procedures, the hospitals, go right down the line. We would live longer. We'd have less chronic disease. We'd be happier. We'd probably save $1 trillion or more dollars. And we could even, with that money, give insurance to everybody in the country. And but with and look, don't just believe us. In our book, we have a whole chapter or two, I think, on primary care, and we have all the statistics that show the more primary care there is in a community, the longer people live, the less chronic disease, the happier they are, the cheaper it is. That's not even controversial anymore.
Right?
But
It's not,
also, the more specialists there are, the opposite. The opposite occurs. The more hospitals are, the opposite occurs. So we are the one. We are the solution. We get 5% of the total budget. Fixing the healthcare system, which we define and we discuss in our book, has to start with primary care. And the only way it can start with primary care is to get more people to go into primary care and to give primary care physicians more tools. And you know what the tool we need, Alan, is time with our patients. That
yeah,
that that is what frustrates most primary care doctors. They don't have the time with their patients.
yeah.
So we need the
I,
time.
I think we
That's it.
I think we definitely need to do a podcast on the whole medical school mess and how to get people to go into primary care because that one's simple as well and wouldn't necessarily
Yeah.
cost a dime.
Yep. So we will talk about that, and we'll keep talking about primary care a little bit in medical school as we move along here. So that's it for today. And again, a lot of this is in our book, and we've written articles about this too, which are on our website, returntohealing.com. So yeah, and
Yep. Please read our book.
Atul Gawande wrote a great article about it too in the New Yorker, about a 30-page article, and he's a specialist. And he wrote an article about how we need primary care. That's the only solution. So that's the guy who wrote Being Mortal, if you don't know who he is. So he's a medical celebrity. So anyway, Alan, have a great rest of the day.
You too, everybody. See you next week.
Okay, take care.